right, well, thank you for having me today, and thank you for being willing to listen to me twice. Really appreciate that. My watch is probably going to be beeping, so hopefully you can't hear it. My nephew is running some crazy 100-mile race in North Carolina where he's going over 30,000-foot elevation gains, so I'm getting like updates from my brother who's there supporting him. So why am I talking about two different topics? Well, in my role, I wear a lot of hats. I'm a professor at the School of Pharmacy, so I do a lot of teaching. I am the chair of our protocol review and monitoring system at the University of Colorado Cancer Center. So I help review all the trials that come through our cancer center. And as well as I'm a clinician and I work as an oncology pharmacist in our GI phase 1 surgical oncology sarcoma head and neck clinic. So I get exposure to patients and patient care. So we're going to start out with my PRMS hat and talk a little bit about diversity in clinical trials. So I have no financial disclosures for this presentation. And so why is diversity in clinical trials really important? Well, we've all seen studies that have come out, shown great benefits in patients, drug gets FDA approved, gets out into the real world, and then something major happens, right? Maybe it's a safety issue, maybe it's an efficacy issue, but what was it about that trial that caused that to happen? A lot of times it's related to diversity, right? The patients in the real world don't meet that really tight inclusion-exclusion criteria. So when we think about generalizability of these studies and the scientific credibility, the more diverse our patient population is in a clinical trial, the better. It improves our understanding of medical and biological relevance of these therapies. It helps us discern side effects, right? In Europe, when capecitabine was being tested, patients in Europe can tolerate a much, much higher dose than patients in the United States. And it's probably related to genetics, right? So making sure, again, we're looking at this diverse patient population to help us look at side effects, quality of life, and even feasibility of these trials. It helps us provide access to get investigational drugs and other treatment options to patients who may not normally have access to them, right? So you shouldn't be denied access because of race or ethnicity or age or where you live. Also, we look at how it addresses health disparities and developing effective treatments for different and diverse patient populations. And then lastly, it helps with confidence and trust. So what is diversity in clinical trials? Well, it's kind of exactly what we think it is, right? This is not a very complex definition. It's really the intentional inclusion of a diverse patient population as participants in a trial. And when you think about diversity, there's lots of different ways in which a patient could be diverse, right? Race and ethnicity, I think, comes to mind most often. But like I mentioned earlier, age, sexual and gender identification, sexual orientation, social determinants of health, genetics, then also looking at health status, like what are the other comorbid conditions do our patients have? If we keep this very tight inclusion criteria, are we really seeing the patients that we're going to see in the real world get these drugs, and how are they going to fare? So when you look at the current state of clinical trial diversity, here on your left is the US Census demographics from 2020. So you can see for white, Hispanic, and Latinx populations, Black or African American populations, and then Asian populations. And then we can compare that to the US clinical trial statistics from 2022. This looked at 21,000 studies in the United States that had about 5 million patients enrolled. And you can see there's an overrepresentation of whites, a fairly similar representation of Blacks or African Americans, but a poor underrepresentation of Hispanics and Latinx populations, Asians, and Native Americans and Alaska Natives. When you think about cancer more specifically, right, so this is a report from the American Association of Cancer Research. They have a cancer disparities report they put out every year, and this is their most recent report. This is looking at the top here, the incidence of cancer in the different race and ethnicities. Again, looking at white, Black, Asian, and Hispanic across liver cancer, multiple myeloma, and prostate cancer. And below that are pivotal trials for key drugs that were approved in each of these areas. And so you can see in liver cancer, when tremelimumab was FDA approved, and looking at the study, right, There's, of course, representation from whites. We have a decent representation of Asians, but not a matchup there with our Hispanics and our African, our Black patients. So you can see that across multiple myeloma the same. You can see that in prostate cancer the same, especially in the Black patient population where we know that population tends to have a more aggressive disease. We really don't see that representation in that clinical trial for the lutetium 177 antibody drug conjugate that we see. When we think of age, right, that's another diversity point, right? So if you look here, you can see new cancers by age group, and the majority of our patients who develop cancer are really between the ages of 55 and 84, right? So that's where we see that huge spike. But then again, if you look at this pie chart and look at the enrollment, and this is just looking at NIH clinical trials, so not broad industry type trials, but again, we see the majority of the patients enrolled are in the demographic of 18 to 64, right? So it includes some of that patient population, but not a large part of what we really see. And so there are patients who are older than 65, only encompass about 20% of our clinical trials, but yet they make up the majority of the incidence of cancer in patients. When we look at where patients live, we can look at rurality or urban versus rural environments. And so you can see in this chart here, this is an age-adjusted kind of death rate for patients across the 10 leading causes of death. Cancer is there, number 2. The blue line is rural patients, and the green line is urban patients. So you see patients who live in a rural area are more likely to die from cancer than those that live in an urban area, right? And why might this be related to clinical trials? You can see here that patients with blood cancers or patients who want to go in phase 1 clinical trials, we have a smaller percentage of those patients that come from rural areas than urban areas. And then lastly, thinking about sexual orientation and gender identity, this is something that the National Cancer Institute is really asking us to begin to start looking at in our clinical trials and as we monitor them. And it's really important to help us determine social determinants of health. Patients who are transgender may not respond to hormone therapies the way patients who identify as male or female do. And so right now, currently, we poorly collect this data. Often it's not collected at all. The forms that we use aren't standardized. Patients don't feel comfortable giving us this data. In clinical trials, it's almost never included as a data point. So really, there's some missed opportunities there related to understanding the safety and efficacy and quality of life of these agents in patients. So looking specifically in Colorado, right, so these are some statistics that we have from our cancer registry and some data that we have here. So you look at the graph with all the blue, right, so this really looks at cancer incidence, mortality, and late stage disparities. So the bluer the area, the later the stage people are diagnosed, the more disparities that exist, right? So you can see there's a big, huge patient population in the southeast Colorado where there's a large majority of disparities. And you overlay that with that kind of teal-green map, right? And this basically is looking at rurality and looking at the density of the patient population. And what we see here, again, is that we see in those lighter greens, that's less dense population. And in that southwest corner, those green dots are counties that have greater than 25% Hispanic population, right? So you're seeing this overlay of these cancer disparities in these large Hispanic patient populations. And we see this when we look at statistics related to incidence and mortality of patients in Colorado. So at the top here, we see our Hispanic patients for breast cancer, lung cancer, and colorectal cancer versus our non-Hispanic patients. And as we can see, the incidence is higher in our Hispanic patients in Colorado for all 3 cancers, and the mortality is higher in all 3 cancers than the national average. Okay, so definitely we see some disparities that exist. So what are our barriers to clinical trials? Right? There's a large number of them, and I couldn't even put all of them on this slide, so I put a few here. There's socioeconomic barriers, awareness of clinical trials, trust issues, right? We saw that during COVID, a lot of trust issues, provider factors, cultural and language issues, and then issues with just the clinical trials themselves. What's the eligibility and what's the trial design? So when we think about the research continuum, right, we typically start with our preclinical research, and there's issues with diversity in preclinical research. Do the cell lines that we use, are they representative of diverse patient populations? We're not going to talk about that. But clinical trial design and development, clinical trial enrollment is something that we'll talk about today. And then later, when the data is being analyzed, are we really looking at these diverse subgroups individually to really understand the efficacy and safety of these drugs in those patient populations? So really thinking about education and awareness, first off, we need to make sure that people are aware of why we're doing clinical trials, so really that research exists for either general or specific clinical conditions or medical situations, and that, making sure they understand the purpose of the research. What are we trying to do? What are we trying to gain from this? All right? And we can create this awareness by really looking at community engagement, right? Working with our patient advocacy groups across the states or across the areas that you work in, hosting community events about research, building relationships with, kind of influential organizations or leaders within the area that people may trust or look up to, making sure that we disseminate information on platforms that people actually have access to, right? If we're looking at a younger patient population, they are not looking at Facebook. So I'm told by my daughter that no young person looks at Facebook, only old people do. So making sure that we're disseminating the information in the best way possible to reach those communities, right? And then sharing the results of our studies, right? If we're asking patients to come in and be a part of these studies, tell them what we found and how their the part they played is really important in that understanding or those study determinations. Looking at provider education, right? So making sure that we're educating providers, making sure they know how to access clinical trials, making sure they know how to refer patients. So that's super important. So one thing that we do from an awareness standpoint at the Cancer Center is that as part of our protocol review and monitoring system, we actually review clinical trials with diversity in mind. So we ask our PIs or our investigators to think about what diverse patient populations could you enroll, and are there barriers to enrolling those patients? And then when we review the trials, we also wear that hat and think about what's the diversity potential for this trial and have we really tapped into that. And then we also provide information to our to our providers looking at what is coming through the door. Who are they enrolling on clinical trials? And we're giving them information about race and ethnicity, age, gender, and role status. So really trying to keep that at the forefront of their minds. When we think about clinical design for clinical trials, really trying to make it just more accessible, right? Make sure that we are aiming to do a trial that matches kind of the diverse demographics of the area in which we are working in. Making sure the inclusion-exclusion criteria of those trials is broad and not overly restrictive if it doesn't have to be, right? Thinking about what's the flexibility. Does a patient have to come in on a specific day? Is there no window? How can we broaden the ability for patients to get to places to have study assessments done? What are the financials? How can we support our patients? Can we decentralize? Can we do remote visits? Can we have them get labs locally versus coming all the way to us? Can they get an x-ray locally or a scan locally? Can we deliver investigational drugs to their house instead of making them come all the way into us? What are some ways that we can do to help those patients who may not live in an urban area? Again, incentives, right, are always helpful and important in supporting patients, especially those who have social determinants of health issues. And then making sure that we're collecting the appropriate data. We also need to think about participant access, right? So if we want patients to participate, we can give them all the information that we want, but if we don't make it easy for them to participate, they're not going to, right? So how can we create processes that allow for easy referral of patients and easy enrollment to patients on trials? Again, that trial decentralization, and most importantly, navigation, right? We have great nurse navigators at a cancer center. You guys, I'm sure many of you out there do a lot of nurse navigation. How do we connect these patients? How do we get them in? How do we address those barriers? How do we, connect them with resources and make sure that they have the opportunity to participate? And then meeting our patients where they are, making sure that they have study documents that are in the languages that these patients may speak, right? So that's very important. And then lastly, just looking at workforce diversity, right? People want to see people that look like them when they come for clinical trials. So here on the right here, you see the snapshot of the state of oncology workforce. You can see kind of down that one side, the age of the workforce. They also talk about the percentage of underrepresented oncologists in the workforce. So only about 4.7% of oncologists are Hispanic or Latino, 3% are Black or African American, and 0.1% are Asian American. So really making sure that we look at how can we increase the diversity of our workforce, increase the cultural competence of our workforce, and really make sure that people can recognize implicit bias. Right? So those are some ways in which we can increase diversity in clinical trials and the barriers that exist. And so we can put processes in place in the institutions that we work at to manage that. So with that, I wanted to have a little break, ask some questions before we get into our next topic. So questions people have? Okay, must have done a great job, no questions. Either that or you just like get through this stuff, we got places to be. Okay, all right, so let's switch gears a little bit and think about, this is kind of an area of diversity as well, thinking about inclusion and how we can include patients. But liver-directed therapies, we're going to spend most of our time, well, all of our time really talking about hepatic arterial infusion or HII pumps. This is something that we've been doing at the university now for about 3 or 4 years. So we've got a lot of experience with it. It was a little scary when we first started, but I think we've got a nice little groove going on with our patients now. So again, no disclosures for this topic either. So when we think about these hepatic arterial infusion pumps, right, hepatic liver, kind of what are we using these pumps for? Well, we're really using them for liver metastasis, right? And we know liver metastasis are frequently seen in cancers of the GI tract, okay? So it's almost usually the first place that we see a metastasis occur in these GI cancers. So if you look at colon cancer patients, 15 to 20% will have liver metastasis when they're diagnosed. In some cases, it might be the only site of metastasis for these patients. And then more than 50% of patients, will if they don't have it at diagnosis, will develop liver metastasis during the course of their disease. For cholangiocarcinoma patients, right, so these bile duct type cancers, if they have intrahepatic, so within the liver, they're going to have disease in the liver. And then we also can have extrahepatic cholangiocarcinoma, and about half of those patients will develop liver metastasis as part of their disease as well. So you can see the liver is just a nice kind of fruitful breeding ground for metastases for these GI cancers. So what are our current options or traditional options? Well, really surgery, right? But you can only cut out so much stuff, and sometimes you can't get in there and cut things out. Radiation, which you just heard about. So Dr. Lanning told you pretty much most cancers can get radiation. And then chemotherapy, right? And most of this chemotherapy, when we give it, is systemic chemotherapy. And so with that, we can't always target just the liver, right? We're just giving chemo throughout the body, and then we're limited by side effects that can occur. And then that might limit our ability to really dose escalate or maintain patients at the doses that we need. So the liver is a unique little organ, kind of fun in the fact that it has 2 different sources of blood supply, right? So it makes it very unusual. None of our other organs have this. But we can really look at this, and we can really take advantage of this when we think about treating the liver with liver-directed therapies. So if you look at the liver, normal tissue of the liver receives its blood supply from the portal vein. And then hepatic metastasis will receive their blood supply through the hepatic artery. right? So because of this, then we can really target the ability to give chemotherapy in the liver directly and not harm the normal tissue of the liver, or not harm it as much as we would if we didn't have the two blood supplies. So this is what hepatic artery infusion is. So HAI is liver-directed therapy where we'll be able to give really high doses of chemotherapy through an external pump. It selectively targets those tumors because we can selectively feed it through the hepatic artery. And we can use drugs that have a high first-pass metabolism. So first-pass metabolism means when we put something in the liver, almost the majority of it gets metabolized and very little will go back out into the systemic area or systemic blood flow. So with that, we can minimize our systemic side effects and allows us to give it concurrently with systemic chemo. So really, HAI can be an alternative treatment to patients. So we can increase resectability, we can increase disease control, and we can see improvement in survival in these patients. We've actually had several patients who had metastatic liver disease from their colorectal cancer. It was the only site of disease. And we've been able to go in, give them hepatic artery infusions, shrink those tumors down, go in, take out their metastasis and their primary, and cure them of their disease. Right, so it's pretty amazing that we can do that. So when we look at outcomes with hepatic artery infusion pumps, right, so this is looking at these unresectable colon cancer patients, right, so those stage 4 patients that come in with disease, they have liver-only disease, and we can give them this HAI pump with FUDR, which we'll talk about in a second, and chemotherapy. And so you can see here in these studies that I've shown you here as a representation, the response rates are pretty high, right? We see response rates anywhere from 55% up to 92% of patients respond. The conversion to resection is phenomenal, right? Ranging around 50% of these patients can be resected. And then we see benefits in the overall survival, right? So, we can see benefits of survival anywhere from 38 to 81 months for patients. For the adjuvant setting, so our patients who come in, no metastasis, we go in and cut out their tumor. We're giving them adjuvant therapy. We give some adjuvant HAI treatment. Again, we see improvement in median survival, recurrence-free survival, as well as overall survival. So when we give it along with our systemic chemotherapy compared to systemic chemotherapy alone. And then in cholangiocarcinoma, again, this is looking at intrahepatic cholangiocarcinoma, we see increases in response rates and improvement in overall survival. All right, so that's kind of the onus of why we really want to look at this as an opportunity for patients. So what is this pump? Well, this is a little pump. It looks like a hockey puck. It's about the size of a hockey puck. I wish I should have brought one with me, or a pump with me, or a replica of me. But it is. It's about this big around, and it gets implanted into a subcutaneous pocket in the abdomen of a patient. So if you have a really thin patient, usually you can see them pretty well. They look a little scary when you see them sticking out of a patient's belly. But most patients, if they have enough subcutaneous fat, you can't really see them. But they are planted in that subcutaneous pocket, and then there's a catheter that goes up, and it goes up into the gastroduodenal artery, and we put it right up into that artery, close enough to where it starts to bifurcate into the hepatic artery, right? So now that drug can go straight into the hepatic artery and go to the tumor. Once a pump is placed, we do a nuclear perfusion scan to make sure that the pump and the catheter are in the right place, and that anything that we put into that pump is going to go directly into the liver. So the only FDA-approved pump is the Intera 3000 pump. It used to be called the Codman pump, if anyone is familiar with HAI pumps. And it really is a very kind of archaic mechanism in which it works. It's really bellows and propellant. It has Freon in it. When you heat the Freon up, the bellows open, the flow of the drug goes out. When you cool it down, those bellows close, and the flow decreases. All right, so it's not kind of high technology here, but it's effective. The volume of the pump is about 30 mils, and the flow rate, if you're at sea level, typically is about 1.2 to 1.3 mils per day. But at altitude, we were one of the first institutions to use these pumps at altitude. We're seeing really the flow rates are closer to 1.8 to 2 mils per day. So we really have to monitor our patients very closely because sometimes the pumps can get a little dry at altitude, and we don't want that to happen. So what med do we use? We use a med called floxuridine. Most people just call it FUDR because it's way easier to say than floxuridine. It is a drug that has a 95% first pass metabolism, so only 5% of the drug could get into the systemic blood circulation. With this, we're able to give a 400-fold increase in the tumor exposure to chemotherapy than what we would do if we just gave systemic chemotherapy. And we really don't see hardly any. I can only think of like 2 patients where I've seen some mild systemic side effects in patients. Most of the time, they do fine. We always give it with dexamethasone just to help with the kind of any inflammation this direct delivery of chemotherapy can cause into the liver, as well as heparin to keep the catheter patent and normal saline. And with this, we can give it with or without systemic chemotherapy. So the dosing that we typically use for FUDR is 0.12 milligram per kilogram up to 0.15 milligram per kilogram. Generally, when we start our patients with systemic chemotherapy, we use kind of the lower end of that range. But if they were getting our HA pump or FUDR only, then we might think about going to the higher end of that range. Again, with that dexamethasone, because to help with any kind of inflammation, and we give it over a 14-day period. All right, so it's infused over 2 weeks, and then a patient comes back, and they get any that's left taken out of the pump, and then we're going to put some heparinized saline in there. That's going to run for 2 weeks. Then they're going to come back. They're going to get more FUDR. So they get the FUDR over 14 days every month, and that alternates with this heparinized saline that we give. Okay. And then if a patient does have hyperbilirubinemia or some other kind of liver dysfunction that we see, then we will add some dexamethasone to that heparinized saline to, again, just help the liver with that inflammation that the patient may be experiencing. Okay. So dosing for our patients. So when we think about how we dose it, right, it's milligram per kilogram, but what kilogram weight do we use for our patients? We always use actual body weight. If they're underweight, we use actual body weight. If they're normal weight, we use actual body weight. The only time we don't use actual body weight is if they're more than 25% above their ideal body weight. Then we'll use what we call an ideal average weight. So this is something that you only see with HAI pumps. You don't see this. I have not ever seen this with any other kind of drug therapy. But that ideal average weight is their actual weight plus their ideal weight divided by 2. And that's what we'll use to calculate their dose. Okay? And it's important for these patients that you make sure that you use the weight from the day they come in for treatment, not their weight from 2 days ago or a week ago or 2 months ago or a year ago. We weigh our patients every time they come in for treatment, right? Making sure that we're using the most appropriate weight for them. So when we are giving this drug, we're monitoring liver function, right? Because if we're giving drug directly into the liver, a really potent drug directly into the liver. So we're going to monitor LFTs. We most specifically look at ALK-Phos, or alkaline phosphatase, our AST, and our total bili. Those are the 3 key labs that we look at, and are going to be the 3 key labs that we make dose modifications off of. So we look at these labs every 14 days when they come in for an FUDR treatment, and when they come back to have that pump emptied and put saline in it, we look at them again at that point. So every 14 days, anytime we're poking a needle into that pump is when we're looking at labs, okay? If the doses, or if their LFTs are elevated above normal ranges, then we're gonna make some dose modifications. And if they're significantly elevated, then we're gonna hold and just put more heparinized saline into that pump until those values come down and we feel safe to treat them again. So this is the algorithm that we use to make dose modifications for our patients, looking at that ALK-Phos, that AST, and that total bilirubin, right? And so you can see here, it's all based on a reference value. The reference value is the value that you get on the day that you are giving the patient FUDR. All right, so if they come in and the reference value for their AST is 3 to 4 times above what that last AST lab was, then we're going to make a 50% dose reduction. Okay, so we use these laboratory values using this algorithm to make sure that we're dosing our patient appropriately to not cause liver toxicity. Okay, and so we will hold it if we need to. We'll dose modify it if we need to. When we hold it, like I said, we just continue that heparinized saline to allow for their liver to kind of heal and repair. And sometimes we've done heparinized saline for 4 to 6 weeks before we can put another FUDR dose in that patient to really allow their liver to heal. And when we do restart the FUDR dose, we start at 50% of our last dose. And just then we'll dose escalate back as long as the labs look good. All right. So when do we give FUDR? If they're getting adjuvant treatment, we try to wait about 4 to 6 weeks before we start treatment with these patients to allow that liver to heal after surgery. If they are palliative, then we can really begin it at any time once the pump is placed. And then if we do have a patient that has a really great response, right, and they are cured, or we're still seeing really stable disease, and we don't feel like we need FUDR, we can put glycerin in these pumps. And this glycerin can go for long periods of time, usually over 6 to 8 weeks. And so the patient only has to come back and get their pump every so often, and kind of in this maintenance period. And we usually try to leave the pumps in as long as we can, even if they don't need treatment, because once you take a pump out, you can't re-put a pump in. All right, because we take the pump out, we leave the catheter, you can't reinsert a catheter. All right, so the pumps typically will stay in as long as we can keep them there, even if they're off treatment, just in case the patient might recur, and we may need to go in and start HI therapy again. Okay. All right, so with systemic therapy, we want to think about what can we use. So with colorectal cancer, we basically can use it with any systemic therapy that we would traditionally give, except for bevacizumab. And in the few studies that we have where bevacizumab was used with HI pumps, we saw biliary elevation and hepatic failure in these patients. So bevacizumab is a no-no with HI pumps, but pretty much everything else for colorectal cancer and cholangiocarcinoma is what you would expect to use and is safe to use with our HI pumps. All right, so what are some complications and things we need to think about in our patient population? So definitely pump-related issues. Infection, right? Putting it into a subcutaneous pocket, a foreign body, right? So we can definitely see infections, and we've seen this in patients. So you want to monitor for infections. Are they getting kind of redness, kind of a cellulitis picture, pain, oozy stuff coming out from around where the pump is? Do they have fever? We really have to pay attention to fever, because what does heat do to a bellow and a propellant? Opens up the flow rate. All right, so we're already on the bare minimum of altitude. We have to pay attention to that. So really making sure patients know to call us if they have any kind of infection, start them on antibiotics, monitor them closely. Sometimes we can see seromas or hematomas form in this pump pocket. And so in that case, we're just going to want to monitor it and aspirate that fluid as we see it appear. Every once in a while, our pumps will flip, right? So the port that's on the top of the pump that you would access the port with is no longer accessible because it's flipped to the backside. So you're just hitting the backside of the pump. So we'll get x-rays to see if that's happened, or send them to interventional radiology and have that pump flip back around. And then, like, as we all know with pumps, there's always patency issues that we need to pay attention to. All right, every once in a while we can see some misperfusion occur with these pumps, and that's just because everyone's arteries in their liver aren't exactly the same. We're not all blueprinted exactly. So there could be some hepatic artery anomalies or just arterial anomalies in the liver, and so sometimes we can see some misperfusion of that. Usually if that happens, patients will start to present with kind of GI ulcer pain. They'll get pain, and then if we go in and look, there actually might be ulceration of the gastric tissue where the chemotherapy is kind of leaking up through other pathways into the gut. So these ulcers can be seen in the duodenum and in the stomach, and rarely in the esophagus. Mostly we've just seen duodenum and stomach. So if you do suspect misperfusion, you need to send them to nuclear medicine for a scan, and make sure that all patients who get an HI pump, this is something that we always have to double check when our patients are discharged from the hospital, is that they get started on a PPI or some kind of acid-reducing medication to help minimize any kind of complication that would come from misperfusion. All right, biliary toxicity, this is a no-brainer, putting lots of chemo into the liver, really toxic chemo, so we've got to monitor, as I mentioned before, really look at what we're seeing in our trending in our labs. Usually if we're going to see biliary damage or toxicity, liver damage, we're going to see alk phos go up first, and then AST, and then T-bili. So if we start to see those trends, we're going to really pay attention and make dose modifications or hold. Like I said, prevention is adding that dexamethasone in during the heparinized saline portions of our treatment, making sure we take our FUDR out at 14 days and not letting it stay in there any longer than it has to be in there. And then if we did see any kind of biliary toxicity, making sure that we treat it appropriately, hold chemotherapy, and even discontinue our hepatic artery infusion if needed. All right, so some things to educate our patients about. So signs and symptoms of biliary toxicity. So we all know what jaundice looks like, making sure that they know what jaundice looks like, making sure that they're taking that acid-reducing medication every day, looking for any kind of possible drug-drug interactions if they're on a PPI or some other acid-reducing medications. We see that a lot with our oral therapies, so making sure that we look at that. Making sure we're having the patients report any kind of elevated temperatures. So fevers, there's no hot tubs, there's no saunas for these patients. That's a bummer for them. No heating pads and blankets. Sometimes we'll have patients after surgery want to put heating pads on there to make it feel better, but then we see our pump like go way high, those flow rates go way high. We're like, take that thing off, please, please, please. So really educating them about that. And then also pressure changes, right? So like as I mentioned, sea level to altitude, we see changes in flow rates. If they go up in elevation, up to the mountains to ski for a few days, right, that's gonna change. If they go to sea level, that's gonna change. You know, scuba diving, non-pressurized planes. Even patients who go ride on planes like to international flights, we have to be aware of that because that can also increase their flow rate. So lastly, educating patients to avoid really strenuous activities. Like I said, this is a subcutaneous pocket, so you can really jostle it or bounce it around or annoy it or scrape it or rub it. So patients need to be aware that to avoid rough physical activity, so no rugby for patients. Jogging is really hard. We have a few that try, but they say it's really uncomfortable. And then just lifting heavy objects. And then most importantly, just making sure that they're really adherent to their HI therapy appointments, because we got to get that FUDR out and we need to put saline in to make sure that we don't damage the liver. So with that, questions? Yeah.
How many doses do they get of that medication?
So the question is how many doses of the FUDR they get. They can be on that for extended periods of time. So we've had some patients, if they're getting adjuvant treatment, then we'll only do about 6 months of therapy. But if they're palliative and we're trying to get them to resectability, we can be a year, 2 years of patients on therapy. Yep.
Do you know of any other pumps that are in development that not have those same effects, like heating, temperature elevation, size?
Yeah, so there's no other pump being looked at for FDA approval other than this one. There are other pumps that could be used. They might be pain pumps or other types of pumps. But the problem is, one, they're not FDA approved, so they won't be paid for. But they do have other features. You know, they're programmable and different types of things that could be used, but I'm not aware of any of those that are trying to seek FDA approval for this indication.
What is the concern about air, that you can't aspirate and it's air gets
Yeah, so whenever you're putting drug in or taking drug out of the pump, you don't want any kind of air to get in there because air will change the pressure inside the pump, and then it will affect the ability for the bellows to expand and contract. And so that's what because it changes the internal pressure of the pump and will essentially bend those bellows so they don't open and close the way that they would normally close. So we have to be careful.
Hi, my question is in regard to the glycerin 50% for 6 to 8 weeks. What's the rationale for that?
So glycerin, the reason why we use glycerin in there is because it's a really thick and dense fluid. So the flow of that is going to be much slower than a saline would be or any kind of other liquid that we would put into the pump. So essentially the glycerin is just there to be a slow kind of infusion over time so patients aren't having to come back every 2 to 4 weeks, right, to have their pump accessed and refilled. So you can use different concentrations of glycerin. We use 50% here. Some institutions will use 70%, which runs even slower. But basically it's just to keep something in the pump, to keep it patent and allow a slow flow over a long period of time so the patients aren't having to come back and be accessed as often.
Can the patient see the rate? Is it
Yep.
something obvious on there? So do you have data collection?
Yeah.
You do. So you would alert them, hey, what's going on? It seems like it's speeding up.
Yeah, so the hard part is that we can't see it in the 2 weeks that they're away from us, right? Because we won't know what their flow rate is until they've come back. We've taken the residual out of the pump, knowing what we put in, what we're taking out, and then we can calculate a flow rate. And so we don't know until they get back, right? So that's why that patient education up front is really, really important for patients to know, heat, changes in altitude or pressure are going to affect that flow rate, and so they need to be really aware of that to minimize any elevated changes especially. Okay, anything else? Okay, all right, great, thank you guys.